So I want to go ahead and welcome everyone to the ITM Grand Rounds in this February. I'm Nathan Shetler from the University of Chicago, and on behalf of the ITM, I'm pleased to introduce Elaine Morrato. So Dr. Morrato is the founding dean for the Parkinson School of Health Sciences and Public Health. Her research really is focused on looking at having an impact on accelerating some of the translational findings in medical decision, or I should say medical innovation, as well as drug safety, and bringing that into clinical practice. Her career is notable for working for a decade and a half in industry with Procter & Gamble, their healthcare division. And she also regularly advises with the FDA regarding drug safety and related issues. So we're looking forward to your talk. Thank you.
Thank you very much. And before I get started with my talk, I want to shout out of gratitude. This is the opportunity for Loyola University Chicago to be hosting the Grand Rounds, and we're excited to have so many people here in the room and people also with us virtually. So it's delighted to be a site in participating in the Institute, and hopefully this will be a talk that might spark some ideas or interest. Where I've decided to focus is on implementation science. And so this is a new cluster of the Institute of Translational Medicine. Its academic home is here at Loyola, but it's in partnership with all of the sites. So it's to talk about what is the field of implementation science and how does this relate to clinical and translational research. I wanted to include some disclosure, just to touch on a little bit in the intro, how I tried to synthesize lessons learned in various settings that relate to implementation science. In industry, you care about scaling some innovation that came out of research, product development, and you hope it makes an impact in the world. And you hope it's sustained, and you're thinking very broad scale up in translation. In public health practice, we're trying to scale up in evidence-based approaches to improve population health. So again, something in which you're taking an idea and really trying to have broad adoption, impact, and sustainability. And really that's the mission, I think, of clinical and translational science. If you look at what NIH wants us to be doing, is accelerating that, to be thinking of new processes and systems in doing that. So a bit of my talk is the applied side of me, and a bit of the talk, you'll get references as well. So that's the academic side of what I do. What I hope to cover in the next 40 minutes or so is 4 objectives. I'd like to share with you, just so we have a common understanding of key definitions and concepts that come from dissemination implementation science. And I thought to make this useful, I would use as an organizing framework a really wonderful paper that was put together on 10 ingredients for successful D&I proposals, written by people who sit on study sections at NIH for this. And what are the elements that you need in your research proposal to be successful? To discuss with you a few of the key highlights or themes from last December and the NIH Academy Health Conference on Implementation Science. You know, where's the field heading? And then I want you to all to be aware a little bit around the resources available through the ITM to help support what you might be needing in terms of implementation science for your research. Okay, so let's start first with the motivation. Maybe you've heard of some of these quotes. The first is from the Institute of Medicine and came out of the Crossing the Chasm series in the early 2000s. It's often quoted, it takes an average of 17 years for new knowledge that's been generated in randomized trials to actually get incorporated into practice. And even then, the application is highly uneven. About half of clinical practice guidelines are adhered to. And if you look at it from a commercialization standpoint, 3 out of 4 startups fail. So there is a clear recognition of a failure to translate much innovation actually into sustainable practice. So why is that? Well, one implementation challenge has been described as a leaky pipe. By the time you go from the looking for priorities for funding, aligning your research with those priorities, applying for grants, resubmitting, getting grants, publishing, synthesizing research, enough of research that you actually can develop evidence-based guidelines, and then getting it into practice, this is a long translational process in of itself. For us in academics, you know, maybe that's more transparent. Each of us are working at various stages along there. In an industry point of view, it takes just as long. You just don't know all of that development is going on until, let's say, they have FDA approval and it suddenly looks like they're launching very quickly. But, you know, it's a long time to make sure we have enough evidence. And that rightly so. We want to make sure that we are actually translating things that are worthy to be translated. The other challenge we face is that implementation is a human process, and human adoption processes are complicated. So it's not just the research synthesis. You can look at the whole field of health services research or clinical quality improvement research. It takes a very human thing for all of us when we adopt something new. You have to be aware of it. You have to accept it's worthy of it. You have to find it's applicable for my situation. Do I have the capacity? Am I able to? I'm motivated to. Will I agree to do it? And then do I have to sustain and keep doing it? And each one of these steps may have a decay curve. So even if you're 80% successful, which is, you know, 80%, that's a really good threshold. By the time you get to the end, that's what's left. Each one of those steps, you may only have 10% adopted and sustaining. So this is no different than a marketer's dilemma in the challenges that we face. And then there's this concept of the valleys of death. You hear this in the commercialization entrepreneurship literature. You talk about, you have R&D, how do you actually get it to the private sector? So this figure on the right-hand side comes from the National Institutes of Standards and Technology. And how do we bridge this gap between innovation at government and universities and actually the private sector? But it's also, if you look at the figure on the left, it's what we talk about all the time when we talk about translation at various stages, going from discovery to a candidate product or intervention, developing the evidence, then practice, then population. Each one of these is involving different communities of people, research communities, but also practice communities. And so just like when you have a handoff between shifts in a hospital, or you have a warm handoff when someone gets discharged from the hospital and you're hoping that their community care follow-up is well maintained, that same process or valley of death can occur in the kinds of translations we're doing, even if it's scientist to scientist. So that's where this field of implementation science and health aims to accelerate and cross those gaps, make the time shorter, and really think about the strategies for reducing the decay that naturally occurs. So when I say dissemination, it's always good to make sure, what do we really mean by that? Dissemination, the goal of it is to spread knowledge. You're targeting a distribution of information, materials to a specific audience. You're disseminating, but you're also thinking about its implementation. And this is the strategies by which you hope you will be using to facilitate adoption and integration of those interventions, those approaches, those programs, so that it actually changes practice and is sustained. So that's why these things are often together. Why disseminate if you don't hope someone actually changes their behavior, right? And you can't just expect implementation if you're not communicating to people what to implement and why. So hence why it's often shorthanded. This is called D&I. And over the last 20 years, this field has been codified in a variety of ways. We now have textbooks. There's a dedicated journal around focused on implementation science. There are standards in reporting, just like consort standards or strobe standards for observational studies. There are leading societies and conferences that hold research meetings on this. And the more advanced systems are integrating these methods in as a learning health system. And the leading one has been the VA in that regard with their query network. So it's an advanced scientific area. And now NCATS and Clinical Science Translation Science Awards in the last most recent program announcement is saying that CTSA hubs are required to also be engaging in these D&I activities to support the research enterprise and capacity building for academic medical research centers like us. So recognizing that this challenge of translation, the science of translation, is really very well aligned with the science of implementation. You may have seen this. This is commonly used to describe the different stages, whether you're at basic science, translation to humans, proof of concept to patients, to practice, or community. And oftentimes when we think of implementation science, we say, okay, we implement once we have this evidence base in patients. And so if I'm not doing work in that area, I'm not at that level of implementation, I might say this is not relevant for me. But where the field is going is to expand in how we think about the translation. That is thinking about sustainability, scale up, and adaptation. In a learning health system, interventions adapt and need to adapt. If we're to address health equity challenges, we've got to adapt to the settings and to context. So for us to truly benefit to society, we have got to be thinking of methods as it relates to the sustainability and fundability of the work we do. It also goes the other direction. And there's a big movement within the field around what's called designing for dissemination, implementation, and sustainability. And this is trying to say early in the process, like I was taught when I was in product development at a company, how do we make sure it's patient-centered? How do we make sure what we're doing is community-centered as we're developing early stages of interventions, so that by the time we are implementing, it's with those needs and requirements as part of our conditions or requirements for success. We're generating the evidence that will facilitate the adoption. And sometimes, and many times, that evidence is not just the clinical evidence. It might be things related to time, to cost, to ease and access. These are the things that ultimately people say, is it worth adopting? How's it going to benefit me? So the field here is trying to increase capacity across all of the translational levels. And that's where health equity, I think, fits in. In the implementation phase, the push is to start to look at more heterogeneity of effects, subgroup analysis. Are you really understanding disparities and the mechanisms of disparities as part of a research question as you're doing implementation? As you're doing scale up and sustainability, that relates to the external validity of your measures. Are you understanding the context? Is that a generalizable context? So what might be done in Loyola Health System, would that work in a University of Chicago Health System? Is what we do in Chicago translatable to Peoria? This is where we think about the scale up and adaptation. What are core essential elements versus what are the things that will need to be adapted? And then early in the design, are we thinking of health equity considerations as it relates to feasibility, accessibility, and is it the intervention we're doing, is it going to be easily uptaken, I guess is the right word, in a variety of settings? So this came out, I think, in some discussions we had within the ITM. Let's say you want to do at-home blood pressure monitoring, and best practice might be saying, well, that's integrated into the EHR system. That's smooth, it's easy. Well, are all hospital settings able to accommodate that ease of integration into the EHR setting? That requires investment. That requires coordination. Maybe low resourced areas are going to have to go and do different kinds of solutions, right? So that's what health equity looks like when you're in a design phase. Okay. So that's the why. That's what we're trying to accomplish as a field, is the science to facilitate the translation. And I wanted to use this next section to talk about a pragmatic roadmap Many of you are writing grants, want to think about how do I integrate in implementation. You might be actually applying for funding mechanisms that require implementation be written in. Many are now saying, what will you do once the funding ends? How are you going to assess that you can sustain this intervention once it ends? And so more of the, I'm noticing in NIH and other funding agencies, they want to know that. That's an implementation science question. So we'll use these 10 key ingredients. It's to give you an overview of the field and to set the stage of what we're trying to accomplish within the ITM cluster around building that capacity around each of these steps. Okay, so the first ingredient is being very clear on what the care gap or quality gap is. And are we clearly articulating what the evidence is that there's a gap in care or quality? We're usually pretty good at that, because we know how to write a significant section. And we say, well, how many people are dying from this? How much is the excess morbidity? What is the cost? That would say there's a gap, right? I think from a health equity lens, we start to think about those gaps also with social determinants of health as another lens to it. It's not just the clinical demographic kinds of data, what comorbidity, what age, et cetera. But we're starting to think about these gap, is it being driven by social determinants? And by some data, the estimate is about 80% of the health of a group of people or a population is actually due to the social determinants, not due to care and access to care. And so as we think in the ITM, caring about health equity in our interventions, how do we start to broaden out from the healthcare setting to be thinking of these health behaviors, physical environment, and other socioeconomic factors as intervention points to improve health? The second ingredient is to say, are you demonstrating that there's an evidence base for what you are wanting to implement or to disseminate? So has the evidence for this program, treatment, or set of services been demonstrated and justified? So that in some circles, you should not be going to scale until it's extremely well demonstrated. It's been synthesized, you have meta-analyses, it's in clinical guidelines. And probably for some of the work that you're doing, it ranks at that level, right? You might be looking at, gee, I need more people to be just following the US Preventive Services Task Force, or basics in clinical guidelines, or this other one is from the NCI, evidence-based cancer control programs. And you might say those are at the very highest level of the evidence. They're very well supported. But the question is, what level of evidence is always necessary? And I think it's also worthy to note that to some degree, it also depends based on your discipline. Some areas, it's not easy to run randomized controlled trials, right? Sometimes it's a setting or context. Maybe the evidence has been demonstrated on a certain intervention in a different setting. You're wanting to adapt it into yours. All right, you don't have exact evidence for what you're doing, but you have representative evidence. And then, of course, it's urgency and time sensitivity. You see this a lot in public health evidence. Clearly, with the COVID pandemic, decisions had to be made that were based on the best evidence that we had at the time. You see this sometimes in FDA approvals. They had emergency authorization. That was a level of evidence that met enough to say we are implementing it, but we're also collecting evidence as we go. So it's easy to say you shouldn't implement anything until it's in a clinical practice guideline. But the reality is it's often more nuanced. And I think more of the field is appreciating that. The third ingredient when you're thinking about writing grants is to include a conceptual model or your theoretical justification for your study design, your strategies, and the variables that you plan on collecting and analyzing. And I like to liken this is no different. If you were to do a biological mechanism of action kinds of study, you would not pass go if you didn't say what was the biological mechanism you're studying, what are the variables, and what's the analyses relationships you're wanting to do. So in implementation science, these are social mechanisms of action. This is how people are interacting and designing and evaluating. And so there needs to be explicit statement on that. So if you do not have one in your grant proposal, that is the first thing your study section will note and get a low score on. So then the question is, well, which one do you use? And this is where it's a bit unfortunate. I think in the clinical mechanism of everything is converging on here's this consensus statement of how we think this disease is happening biologically or mechanistically. Maybe there's some new areas you're figuring it out, but there's a coalescing that occurs. In implementation science, there are common behaviors, but there's a fragmentation of frameworks and models. And so it's hard to know which ones to use in which settings. Some are frameworks that are very good if you're trying to do like individual behavior change. That might be knowledge, reason, behavior action. Others are good if you're thinking about scale, that's a diffusion of innovation. Others are good if you're thinking about a clinical setting, right? So here is where, just like you might work with a biostatistician to say what is the right study design, the right analytic plan, working with an implementation scientist says, what is the right conceptual model you might select and use and justify. I put here, if you go to the National Institutes of Health, they have repositories of various models that you can choose from, various measures that you can choose from. And we'll be talking more later about this is a key theme of frameworks for our seminar series, is to introduce you with some very common, easy to use frameworks to get started. Once you have that, another key ingredient, and this is why it overlaps so wonderfully with the community engagement cluster here within the ITM, is there a clear engagement process of the stakeholders in place? Because it's not just someone coming in and saying, thou shalt implement. There needs to be an understanding of process, workflows, how the systems are working, so that you are really designing something that is human-centered in its design and will be fitting into that workflow stream. I like to use this. This was some work I was when I was involved in the CTSA at the beginning of the comparative effectiveness and patient-centered outcomes movement, was thinking about stakeholders as 7 Ps to really make yourself think, are you being complete when you think of stakeholders? Usually we work with patients or population community, and so we think of them immediately. We often are working in clinical settings or some service setting, and we go right away to providers. But there are also people who purchase, who pay, who are the policymakers, who are manufacturers that might be involved in trying to do similar things, sometimes aligned, sometimes competing with what you're doing. We'll call them product makers. And then there's other principal investigators, because we need another P, but really other research community. And how do we learn from one another, right? And so thinking about the engagement from the whole ecosystem, not just the patient, not just the physician or nurse or pharmacist, but really all of these stakeholders, because they're all involved in a very complex healthcare system as it relates to adoption. That's why when we talk about what we're doing as a cluster, it's not in a vacuum. We've got to interact with the other resources like the community engagement cluster, for example. Okay, so the other key ingredient, regardless of this, where you're implementing, is that setting or that context. What's their readiness to adopt a new service, treatment, or program? And how are you incorporating that information, that capacity, that desire for change into what you're proposing as your strategy or adoption, right? So you'll see this on grants. Someone might say, I'm doing this wonderful intervention in my health system. And this system has a lot of bells and whistles, and they can do a lot of really cool things. But the implementation scientists will say, okay, how are you gathering information in that implementation to let you understand what's the core essential ingredients and what are the ingredients that you can adapt Because when you're out of that really cool health system, how's that going to work in low resource systems, right? So that's getting at, do you understand what level of readiness your intervention is operating in, such that you can think about the generalizability of it when you actually get the results. So with lots of what we do, there's lots of frameworks. So this is a very good one. As you start to think about diffusion of innovations in health service organizations, of which hospitals, public health systems, healthcare clinics are there. And you really, when you start to think of it this way in readiness, there are many key questions to be asking that inform you. Some of these you might decide you need to collect data on. Some of it might be questions you engage when you're doing the formative work as part of your stakeholder engagement. But it's to make sure that you're thinking about these various linkages with resources, who's using it, who's providing the service, et cetera. From there, you're able to say, what is the specific implementation strategy or process that you're deploying? Have you justified it conceptually given that setting? And what's the experience of your team actually operating that setting, treatment, or implementation process? And does it match? So in a grantsmanship way, who do you have either on an advisory board? Who do you have as part of your research team? So bringing patients or community members, so they're actually real co-research team members with you. That's where it fits in saying, do I have demonstration that the experience, I have the right people who are going to know how to operate in that setting? You know, in a global health intervention, if you're doing work in Kenya and I'm here in Chicago, give me confidence that you know what you're doing, that if you're trying to implement something in Kenya. We know that very intuitively. Well, that's the same thing. I might have a lot of experience operating an urban center, but I'm trying to do something in a rural context. Have I really worked with folks in rural? The other key ingredient would be feasibility of the design and the methods. So is it feasible to actually conduct in that setting? And then how are you thinking about contingencies that might be actually adaptation that you might have to do along the way? So this is where it can be different than an efficacy study, right? In an efficacy explanatory study, everything is extremely tightly controlled. You're not allowing for variation. In fact, you don't want variation because that adds noise to what you're trying to evaluate. In a real world pragmatic setting in which you're implementing, that noise is going to happen. And so you have to be very attuned to collecting that information and to think about, just like you might would with a drug safety monitoring board, about what you might see and how you take that information to adjust how you're approaching a trial. That's sort of the equivalent version if you're implementing, let's say, in a large scale practice setting. So this is a well established framework that helps you think about, if you're doing a trial, to what degree are you on a continuum between an explanatory level, i.e., and a pragmatic level, i.e., effectiveness. And you go around this little wheel, and each one of those is a trial design decision. How flexible will you allow the intervention? How much expertise needs to be present in order to do the intervention? Do you care about adherence? How are you going to do an intent to treat or a protocol per protocol analysis? How much are you going to follow up to make sure there's 100% adherence and you don't want loss to follow up? Each one of those gives you a sense of where on that scale. And things that are more implementation, real world, are going to be more pragmatic, because you've got to be in order to operate at a community population level. And in intervention studies in which you're still at the effectiveness, evidence generation might be more on the explanatory. So this is, I found, a very useful tool when you're at the study design phase. The other is to think about, depending on where you are, intentional collection of adaptation that might be occurring. There are frameworks. This is a well-cited one called FRAME, on how do you think about collecting data on adaptations and modifications, not as an afterthought. but as an intentional design consideration. And, it talks about process measures, reasons why there's might be adaptation, what level, where was the adaptation? Was it in content or was it in the training, education, et cetera? And thinking about, again, this is data collection that helps you understand might be heterogeneity of the effect, helps you understand why there might be low or higher adherence. And this gives information that's mechanistic on the social behavioral aspects as it relates to implementation and adoption. The ninth ingredient would be your measurement and analysis plan. And does that logically relate back to your mechanism of action? Just like you do in a biological mechanism, your variables need to nicely linked. It needs to be that way as well in this kind of work. And really thinking about the analysis around what is your source of data for this information. And this is where and why in implementation science, you often see what's referred to as mixed methods. It's an intentional part of the study design. You might have a randomized trial component in which you're collecting traditional clinical efficacy endpoints. And then you might have an aim that's trying to understand the mechanisms, the barriers, the facilitators for how it was used. And maybe you're collecting that qualitatively, focus groups or key informant interviews. Maybe you're collecting survey data that you want to link with what you're collecting clinically to help understand and enrich the types of variables. Maybe you're doing a trial and you're wanting to use EHR data and you want to include social determinants. And so you're going to pull those data from other sources. Maybe it's a direct ask, maybe it's a survey, et cetera. So more sophisticated studies are really thinking about the mixed methods and aligning the methods to what the questions and needs are. And that relates back to when you think about who's on your research team. Do you have the methodological expertise to justify that you're able to do the qualitative as well as the survey, as well as the traditional data collection? So really thinking intentionally of who is on the study team. So some other common considerations as you think about the study design and the aims and therefore the data that you're collecting is thinking about what stage you are in the implementation. This was developed by researchers out of the VA and has been integrated into the query roadmap for implementation and quality improvement. And they describe this as an effectiveness implementation hybrid trial designs. Again, thinking where you are on the translational spectrum. In which has clinical effectiveness been affirmed, efficacy or effectiveness, or are you at completely, everyone agrees this needs to happen, it's completely implementation. So the clinical effectiveness side might be, here's a new cancer care. We're not quite sure if it works in this particular patient population. Before I start implementing it, I probably need some additional efficacy data of some sort of evidence, right? On the far end, on the implementation might be, hopefully, we all agree that fluoridation in water is probably a good thing as it relates to caries prevention, tooth decay, right? And so the question now here is, we don't need to keep showing the evidence of that. We've adopted that evidence. Really, it's an implementation problem. Might be attitudinal, might be policies, et cetera. We don't need to go back and show the effectiveness of how fluoride works, for example. But there is this in between in which maybe some efficacy has been shown in small group setting. I'm wanting to implement it in the real world, but I'm not quite sure how I'm going to be scaling this intervention or program or service in the real world. So I'm in this orange bar area, this continuum. And depending on where I'm at, I might be at a type 1, 2, or 3. And that has to do with the nuance with how I think about a primary aim versus a secondary aim. And by the, at the type 1, I'm really still focused on showing effectiveness. And I'm trying to understand a little bit about the barriers, et cetera. That's a secondary aim. And in the middle on the type 2, you're really much more about the feasibility, the impact of the implementation strategy itself. And by the time you're at aim 3, really, your primary aim becomes implementation questions, and you're just affirming the clinical outcomes, right? And so in a study section, people will say, I'm going to use an effectiveness implementation type 2 hybrid study design. And I'm going to do a pragmatic trial. And there are more sophisticated methods. You might say I'm going to do a step wedge design because the unit of analysis is at the unit of the healthcare system, not at the patient level. So this is how implementation scientists talk about study design. And then lastly, a key ingredient would be thinking about, you show your evidence, what's the environment such that you're going to be able to sustain that evidence or implementation? So does your proposal consider how will your initiatives align with policy payer trends and priorities? Are there issues of sustainability that you're considering and should be addressed? These could be data variables. This could be qualitative information. This could be key informant. It could be you have an advisory board that has expertise in this area so that you're taking the evidence and thinking about it, sort of pressure testing it versus what would I really need to sustain this information. So here are some emergent models in this area. I've been more involved in this, what we'll call fit to context. And that is thinking about it as a concept, as an iterative product design process from the standpoint of conceptualization, the design of what you're doing, the dissemination and implementation of it, and then thinking about the scale and impact. In each one of those time points, you're reiterating on implementation considerations and ensuring that it's fit to context given the outcomes. And so this is thinking about it as a learning health systems approach, but doing it in an intentional way so that it is part of the study design itself and data collection. This here is a framework that's come out of Washington University in St. Louis, and where they're pushing us is to make sure we're thinking about benefits that are not just clinical, not just community and population health, but also how do we think about economic benefits of what we're doing? This is why people sustain and adopt. What are the policy benefits of the evidence that you're generating? And have you thought about how you're collecting information for those stakeholders that shows the relevancy of it? So this informs what are other variables that you need to be collecting as part of your work. So it's all with the idea of translation. I think this is a framework, and depending on where you are in the translational stage, you're not going to need all of this. This is like the Cadillac version of implementation science, but it might show there's elements of it depending on what stage you're at that you might say, do I really understand the care gap? I'm early on, I'm doing the basic science work. What is the care gap from the perspective of society? And how am I aligning and talking about what I'm doing from that perspective? Or if I'm a T4 translator and at the policy level, do I, how might I inform backwards to generate new clinical evidence to get the evidence that I need to ensure adoption? Okay, so that's what we're trying to build is the capacity for the ITM to be for researchers wanting to operate on this implementation scale. That ability to be facile across all of those 10 ingredients. I have just a couple of slides of here are the emerging themes or topics that were discussed in December. And it's really bringing a systems lens to what is implementation science. So the plenary session topics were around health equity and implementation. How do we really be considering health equity at the design phase, implementation, and the evaluation phase? So we are well positioned with the ITM to have a theme on health equity and how we are operating across all of our functional support on this important topic. It's rethinking implementation from a partner perspective. Not just here's what I did in my academic setting, but really embracing the stakeholder, public health, healthcare, and community systems as one. It's thinking about data systems from the standpoint of implementation performance. The ability to monitor real-time implementation so that we as a learning system can optimize access, quality, efficiency, et cetera. So as different parts of the ITM talk about building out a sociome, which is taking the electronic health record data and integrating in social determinants. This is the kind of data set. How do we use it also as a surveillance implementation performance data set to address this? No different than as we thought about COVID, right? Uptake of vaccines, uptake of testing at different sites, that demonstrated why we need to be operating at a systems level, the pandemic. And then key piece here is how do we, as we communicate, disseminate, always keep in mind misinformation and its impact. Because ultimately implementation at any of the stages is dependent upon trust. And do people trust what we're saying? And part of trust is engagement. I trust you because you've engaged with me, and I'm part of the co-creation. But how do we start to think about dissemination or communication science as it relates to this? And as emergent AI and how that's going to disrupt how people are communicating, writing, and all of that, that's going to be really interesting. Do I trust what I'm reading? You know, I don't know how that's all going to ripple out and how that might affect how people are trusting information that we're trying to disseminate as it relates to health. There were a number of forums and workshops that were skill building. I want you all to be aware that the Agency for Healthcare Research and Quality has a long-standing evidence-based practice center program. And some of this was defunded during the Trump administration, but it's a wealth of this kind of implementation evidence over the last 25 years and methods in that that can be examined. It also talks about integrating equity into the design and quality improvement. So you'll be seeing how we're trying to bring that more to us, selecting the right effectiveness implementation hybrid. So people going to the conference are also trying to figure out how best to write these grants. So it is a capacity building, thinking about qualitative methods in implementation, the techniques, and then demonstrating the benefits as well. So the field is all learning on this as well, and we want to make sure we're bringing the latest best process to that. And that's where it comes to what are my last part here, which is the ITM resources and our implementation science cluster. We conceptualize this as in partnership with the community cluster, in that we are providing tools, methods, advising, mentorship, working in collaboration with the community cluster, which is that stakeholder engaged component, and in collaboration with other clusters around methods, et cetera, so that we're all working together toward the goal of health equity. So I'm just going to walk you through our 3 aims and do the mini commercial about some of the resources that we hope that you enjoy or take part in. The first aim is, and I should say also, so I am directing it, but my associate director is Elaine Morrato, who brings extensive expertise in community engaged research and in health equity based research. So together we are leading our mighty team or cluster. Fran Weaver, who is a leader in implementation science in the VA system with the Query Network, is working with us so that we're transferring education and knowledge from other systems to ours so that we might foster a learning community within the ITM and act not as we are reinventing the wheel, but rather as a conduit for dissemination and integration of existing knowledge from other locations. So as we build out over time, asynchronous learning, synchronous learning like today, as well as the webinars, and then subject matter research consults. So they come in as consult requests through the ITM, and if there is one that relates to implementation, we become part of that. So we're seeking to connect so that this work, for many that are doing training development or they're doing a TL1, KL2 development plan, oftentimes our kinds of training is a great thing to write into your professional development plan. But we're also working closely with those in the TRIO studios, bird study design as well, right? So how do we all bring these tools to these other groups of resources at the ITM? So in that mind, we're kicking it off this spring with a focus on frameworks. And so I'm giving an introduction in March. Our webinar will be led by Kathy Beauvais, talking about the CFR framework, which was developed out of the VA. It brings a very clinical focus to our implementation work. Fran will be doing the April session and talking about other commonly used frameworks. And then Nayali will be closing off this semester with really thinking about it from the standpoint of health disparities, work, and health equity. What we're hoping is that those of you that are interested and sparked by this provide feedback to us on topics that you might want to see going forward. So we might think of each year as a thematic year. At my prior institution, we had a whole year on pragmatic trials. There was a lot of interest in the design of pragmatic trials, and we built out a whole learning series on that. And so we really want to listen to you, our customers, so that we're designing things that are helping you right now. The second aim is what I'll call stakeholder-centered design. And we have Michael Bloom and Merle Thomas, who are with the school's Center for Health Innovation and Entrepreneurship, who are our leads in the ICOR program at NCAS. Now, ICOR was developed by NSF with a serial entrepreneur out of Stanford. It's been largely used to help academics learn tools and methods for translating to commercializable innovation, scale or setting. We've been adapting it with the idea of sustainability. Many of us are working in a nonprofit setting, a policy setting, but still, from a business standpoint, you have to show a sustainable financial model in order for someone to adopt it. So that's where this program fits in. There's opportunity for those that go through it to be able to apply for some customer discovery C grant dollars to not just do your interviewing and understanding here locally, but to get out of the Chicago area. Here's the paper that goes with what this is, but essentially in our short course, you're gathering data to say, can you articulate the value proposition? For whom, for why, the problem, what are you providing, provides what solution? How is what you're doing different than what alternative options are? And what really is your primary state of differentiation? That would say, this is a reason why you should be implementing my idea. From this simple hypothesis, you can really do a lot to guide what data evidence you need to collect along the way. So we have a cohort starting next week, and we plan on having these twice a year. And we also are offering it in a graduate study course, an online course. I should say that the ICOR is virtual, that you don't have to be on one of the campuses. And we're also doing it as a graduate course for those that want to write it in a little bit more from the standpoint of this is a research methods as opposed to the quick start version of the short course. And if you're interested in more on this, just reach out to Nayali or myself. No prerequisites. It's really designed to help you get started with this designing for dissemination and sustainability. And the last one is, as we get a cohort of people now more familiar with the terminology, with the training, next year or soon, the funding will be next year, I should say. We are deploying an implementors in residence, so the entrepreneur in residence, the commercial version. We're thinking of this as an implementors. We have a number of individuals who are expert in their area and serving as ambassadors. We envision 3 settings or tracks. And this would be able to have people apply for one-year mentored awards. And out of this, we hope to build a knowledge map of generalizable learning and translation that's going on. We're connecting this with the community cluster closely. So stay tuned to hear more on that. A prerequisite or a co-requisite will be to do the ICOR program, because we want to make sure that we are designing and implementing things that truly are a value proposition to the stakeholders that we're engaged with. So I'll stop there. Stay tuned. Stay tuned for next week, I think. Is that right? Am I hearing that right, Julie? Next week, people will be receiving a needs assessment survey. And we want to be listening very closely. How many of you are even thinking about issues of implementation or design? What are you currently using? Where do you have need gaps? Because that will help guide us so that we are continuing to develop resources that are meeting your need. You are our customer and we want our value to be back to you. And I put this in here as well. The best way to stay engaged with what is happening and being on the listserv is to join the ITM newsletter. For those that haven't already, I bet many of you have. That's how you found out about the grand rounds and why you're here. But you know, if you haven't, please do join, because that will be the best way to stay informed of these funding announcements, training announcements, and other opportunities like that. So I will stop now. I see I did pretty well. 10 minutes before. I see food is here for those that are online. I'm sorry you don't get the wine and the beer that are here. So I'll stop and open it up with questions. Yes.
I really am interested in the point you made. It sounds like you discussed at the conference around mistrust. And in what ways you view that as an implementation problem? I mean, you talked about fluoride in the water or a vaccine, but if people are unwilling to do that because they don't trust the science, they're not going to implement it. So what do you see as the role for implementation science? And how do you frame that as an implementation science problem?
Yeah. So for those that may not have heard, the question was for the issue of trust. For instance, fluoride or vaccine uptake, if people don't believe it, how is that an implementation problem or question to be solved, right? I would say that would fit into the piece of it is that setting, where is their readiness for change? That question that I asked early on, it would fall into that. How are we communicating the benefit? That's a dissemination question, such that it is best meeting the need, answering the issues or barriers. So that's a dissemination. How do we frame our message such that people see value in it? Now, it's very easy. Let's just take COVID vaccine, right? What did we see? Is it effective if we just say it's FDA approved? For some people, I work with FDA, I go, yeah, I trust FDA. And so it was enough for me. Others had other questions. You know, our circle group here in the Maywood area worked very closely with community, with student, with adult, you know, peer-to-peer kind of messaging with student age to their peers. Why am I doing this and being part of it? So there's a whole science of how do you communicate effectively, persuasively, and it's not just telling science at people, it's how do you tap into the emotions and other reasons for them to motivate. So that is a component of dissemination and implementation science. Does that get at what you're asking? Yeah. Okay. Yeah.
Well, Elaine, wonderful talk. Thank you. As I listen to you talk, I learn more and more about this. I think someone in the T1 and T2 area. One comment, it's interesting that you bring up fluoridation in water is something we all accept. But my favorite movie is Dr. Strangelove. I don't think we saw it. It was all about, you know, the guy went nuts because he thought he was accounting fire. Anyway, my question is about this concept of adaptome. You mentioned it toward the end. Is this your own framework? Is this something that's well accepted? Could you expand on that?
Yeah. So this is where I'm hoping we can inform the science of translation by what we're doing. So the newer RFA for the CTSA program is how are you advancing the science of translation? So one of the leaders in the field, David Chambers, who's had been at NIMH and now is at NCI, coined this. And it's in the realm as you've done an intervention of some type, you're now going to community, and we're noticing things are being adapted, adaptome, right? They're getting adapted in different ways in different contexts. Are we measuring where there is upregulation? That is, it's working better than what it what we would have predicted from the trial. So maybe that adaptation is improving the intervention. Or is the adaptation as it goes into real world setting actually making it worse? So we've made it easier to do something because it got more uptake, but it's actually less effective that way. So in his paper, he talks about it as a knowledge map. And that are we collecting every time we're doing an experiment from into the real world and interventions, are we gathering data to understand what are the factors that are making it look like it's getting better in the real world versus not so better? So collectively, that knowledge map he called an adaptome. I think we have to figure out how that translates to our setting, but the way I'm conceptualizing it is a little bit from my time when I was at Procter & Gamble. If you were developing a new product that, they make Crest, right? And so the next time you roll out a new toothpaste of some type, there is a tremendous wisdom around what works in different settings. And they gather data to say what works in this region of the country might be different than that region. For them, the uptake is sales, right? So it depends on what that is. But there's like this collective wisdom archetype. They'll collect it in a way like, here's an archetype, here's common practice. So anytime I'm planning to commercialize the next thing, I'm not having to reinvent the wheel. I work off of what is already a platform or a framework of what's worked before, and I'm adapting as I go along. So I think what we'd like to do is for each project that is doing that implementation, how are we with extracting generalizable knowledge out of it? So someone is maybe doing something in the hospital. There's very specific to that setting in the hospital, but there's probably some generalizable things, right? Here's how the hospital makes decisions. Here's how different, where is the priority? How is the adoption process going? What are the issues? There's some generalizable knowledge that would be how we pull it into a knowledge map. So the next team going forward with a hospital intervention is not having to rediscover these things over and over again. Does it?
Yeah.
It's a little bit, there's not like, it was a conceptual paper he had. So this is our creativity of how do we make that work so it's informing what we're doing across our different institutions. But we're a natural experiment in that we have 6 different health kinds of systems. So that's where we have to think about how do we do this in a way that's it's advancing the science, but also is pragmatic for the next people developing interventions. I don't know, does that help a little? Yeah. We have to, oh, yes, Dr. Singh.
Elaine, a very nice presentation. I had 2 thoughts that I'm not sure how well connected they are. I'll put it out there. Is the definition of dissemination and implementation science sufficiently well understood and consistent to support the promise of not only translation but reverse translation? And what I mean by reverse translation is so many of us that live in the T0, T1, T2 arena develop our fundamental mechanistic hypotheses on the basis of an observation in society. And I was curious if there's part of the challenge will to create a common understanding of what dissemination and implementation science is, even among those of us who are in the biomedical science space.
So the question is there enough common understanding of what dissemination and implementation science is so that it's sort of a common vocabulary?
Yeah, one interpretation I might suggest is someone might in fact be led to this idea that dissemination implementation science is really much beyond where someone who spends their time in mechanistic research is. And if that's the challenge, and then it's a call to action, how can we as a community help that?
Right. So I think you're hitting on exactly where the field is going. So the question is, historically, people thought of implementation science. I don't do that until I have the evidence. It's sort of like, I'm not going to implement a new drug until FDA is approved, so don't even think about it. That's not me, right? So I would agree. So if you went back 20 years, that was a lot of it was in the space of translation to practice and policy. I think there is more of a growing awareness that these tools are useful design stage. And so that's where the new growth is and the new interest is. If you look at FDA regulated products, they'll use the word patient-focused drug development. That's basically like patient-centered outcomes research, which had been a T3. Patient-focused drug development is, are we integrating the voice of the patient earlier into that early stage? Now, you know, how early, right? But often at that stage, the voice would be, how are patients valuing different benefits and risks? So if I'm looking at this new entity and I'm trying to decide, you know, is it worthy to carry forward like a company would, they're looking at what's the anticipated profile of this idea, given what else is being developed and given what is already in the market, how do I take that knowledge and move it forward? So you could say, and this is an area that I'd like to build out more. You don't see as much about D&I for basic science, which I think it could be. In the industry side, basic science is informed by the commercialization development, and they are the ones driving the investment decision in certain areas, right? And so they aren't bringing that back in, right? I think there's opportunity, like how might we at the ITM think about implementation science for exactly that stage of investigators. So it's useful. We're not forcing people to go out and say, well, I already know people want to have a cancer cure in this area. It's like, what are the variables that will help you understand you know, you're often making decisions around it as you select it. Do you upscale the efficacy, but how much risk can you tolerate? You know, those kinds of benefit risk, you know, is often occurring in that, you know, how you're, you know, it's like a type 1, you know, what it be type 2 error. Anyway,
We have one last question.
One question more.
From the
chat.
from the chat. Sean, are you able to speak?
Excellent.
Yes, Elaine, wonderful presentation. So I noticed that the 7 Ps and some other Madison Avenue concepts are built into your framework. And I wondered from your time at P&G whether the issue of audience segmentation was applied to, I guess, customers who may have issues with trust, low resource communities, that kind of thing, that have been successful, that might be applicable and adopted to implementation science clinically. I'm thinking of things like precision medicine, where there's issues around trust and with the medical community, for example. Is that something that is, in terms of the place and the people and the promotion, we could learn from Madison Avenue about? Maybe not from nefarious things like tobacco industry,
Yeah.
but for, you know, or big food, but some success stories.
Yeah, I think you just came up with a theme for maybe next year's seminar series and how we might pull in examples to exactly your, but yes, I think we don't do enough in audience segmentation, both whether that be patient or whether that be provider, right? So from the Madison Avenue standpoint, if a company is selling to physicians, there are, I'm trying to think, I think it's 5 or 7 common archetypes of a physician and how they generally respond to the adoption of new things. And that can lead to common 5 or 7 archetypes and the kinds of objections they might anticipate that person will have when they're thinking about adopting something. And so then they think about, okay, what evidence do I need to generate in order to be persuasive, right? We think of it, you can look at it in the vaccine uptake as it got more sophisticated with COVID-19. Is it helpful to say you're the segment that you're the vaccine refuser? That's not a very way of building trust to say, thank you very much, you know, but it's really, how do I segment based on their knowledge, their attitudes, their beliefs? You mentioned also resources and settings, you know, I think that's where there's opportunity to bring that kind of lesson learned and not try to do one size fits all. So we'll take your comment under advisement, Sean, and maybe we can think about some speakers in that regard.
Great, thank you.
Is that it? Thank you. Thank you very much.
Yeah, there's food and there are refreshments for the